I think we can start.
Yes, sir.
Okay, good evening, everybody. This is Balaji welcoming you to this webinar from MQ Pharmaceuticals. We have the pleasure of having Dr. Kumarasamy, our distinguished speaker for this evening's webinar. But before that, a few words about what we are about to embark today. We have all been accustomed to the HIV treatment guidelines with the 3-drug therapy for decades together. And now in 2021, we are embarking on a paradigm shift of seeing how a 2-drug regimen can come into play. There are a lot of interesting things that are happening, but the first of the lot that has been approved by US FDA and also featuring in many of the guidelines is now available in India and worldwide. And to take us through the session, we have the pleasure of hearing to Dr. Kumarasamy. And to introduce Dr. Kumarasamy, I have my colleague, Dr. Rohan Gurjar, who himself is a distinguished scientist. He did his MBBS. He was then with NARI working on nevirapine and efavirenz in TB co-infected HIV patients. Before he went on to do his MSc Pharmacology from the Northeastern University, Boston, and then his PhD from the University of Liverpool, where again he was involved in studies, pharmacokinetic and pharmacogenetic studies pertaining to darunavir with boosted darunavir with raltegravir compared with boosted darunavir with tenofovir FTC. Dr. Gurjar is currently involved with the clinical development of India's first mRNA vaccine. And over to Dr. Gurjar to introduce our distinguished speaker, Dr. Kumarasamy.
Thank you, Mr. Balaji. Can we have the slide up, please? Next slide, please. Oh. Okay. Good evening, everyone. So I'm Rohan Gurjar. It's my pleasure to introduce our speaker for the evening, Dr. Kumarasamy. Dr. Kumarasamy is a Chief and Director of VHS Infectious Disease Medical Center in Chennai. He's a director at Chennai Antiretroviral Research and Treatment, which is CART for short. It's a clinical research site of US National Institutes of Health, which conducts many clinical trials for therapeutics, as the ACTG, and prevention, HPTN. He's been the clinical investigator for a number of projects with the Brown University, University of California, Harvard University in US, and University of South Wales in Australia. A clinician and a researcher in infectious disease with more than 25 years of experience, he has published more than 400 manuscripts in peer-reviewed journals. Additionally, he is the advisor and expert panel member of WHO ART Treatment Guidelines Committee. I would now request Dr. Kumarasamy to please join the stage and give his presentation. Also, to the audience, I would say that in the chat section, please feel free to ask any questions. I'll be taking them down, and at the end of Dr. Kumarasamy's presentation, I'll be asking him. Sir, please go ahead.
Thank you, Dr. Rohan, for the kind introduction, and thank the organizers for inviting me to do this presentation this evening. And good evening, everyone, and thank you for joining this Saturday. So what I'm planning to start today is I'm going to talk to you about the role of 2-drug antiretroviral treatment for the future of HIV management. Maybe one of the organizers can tell me whether, can you see my slides?
Oh, perfectly well. Please go ahead.
Okay, great. So today's my talk will be very limited to mainly on the role of 2-drug antiretroviral treatment. I assume most of those who have joined this meeting has already been practicing HIV medicine, prescribing antiretroviral drugs, either first line, second line, or third line. And you may come across a variety of patients where the current line of treatment, while they're on antiretroviral load, will have some issues. So you may need to ponder on what could be the best options. So we have some options available based on the recent clinical trials, and some of them have been approved for use, which I'll be walking through that in the next 30 to 40 minutes. Before I go into that talk, I like to again warm you up to show all those various antiretrovirals which have been approved for use for therapeutics. And we have got different class of drugs where you can see this. Some of them I put some strike on that. These are all used to be wonderful drugs, but because of lack of efficacy or because of side effects, they have been removed out of our guidelines. And we do have newer drugs joining this group every 3 to 4 months. One of the newer ones which join now approved is called the Cabotegravir, which is an injectable form, which again I'll talk to you at the end of this talk. I'll also quickly walk you through some of the new changes happened in the last 1 year in this pandemic in terms of treatment options. But again, starting treatment, what had been recommended in 2019 is continued to be the same. The preferred therapy to start for first-line treatment is a combination of tenofovir, lamivudine, or emtricitabine, or dolutegravir. We call it as TLD. And again, today we do have guidelines on same-day ART. Someone who is HIV positive, counsel them, no opportunistic infection, put them on this TLD the day one, and make sure that they take the drug and do appropriate counseling. And if they have any opportunistic infection, make sure that they are treated, and within a week you start them on treatment, except in cryptococcal and other meningitis. But the options what we have used on TLE is efavirenz is completely now gone out of the first line. It's only in special circumstances where either dolutegravir is not available or cannot be used. Also, we have an alternate option, which is with the efavirenz 400. Again, not been recommended anymore because of various concerns. Hence, the preferred being, the dolutegravir with tenofovir, lamivudine. Also, we do have an option with the TAF currently available in India for a special population. I'll touch upon during the course of my talk. But on the other hand, again, by showing that, also I will walk you through the need for 2 drug options. Also, we do have now second-line options with the dolutegravir. Someone who failed efavirenz containing therapy, you can also move them to dolutegravir along with the 2 NRTIs. Earlier, we gave PIs, but now dolutegravir has been preferred. This is based on a study called Dawning study, which showed superiority as compared to a boosted protease inhibitor, which we used a lot for our second line. Also, our earlier guidelines said if you used NRTI, for example, AZT3DC or tenofovir lamivudine, you have to optimize NRTIs for second line, from AZT to tenofovir, tenofovir to AZT. So this is again following one of those data which our group and several others in Africa put together called Nadia Study, where we showed someone who's failed tenofovir containing therapy for first line, they'll fail anything from 39 to 57% of them with the K6 to PR mutations, 39% in Asia, 57% in sub-Saharan Africa. And because of that, you have to optimize it. That's what the earlier guidelines said. But again, very recently, so now just presented early this year in the CROI and now got published. This is a study called Nadia Study. So what they did is patients who have been failing TLE, and they randomized into 3 different groups, and one group received it's a different types of randomization they gave. One group received dolutegravir, another group received darunavir 800 milligram with 100 milligram ritonavir for second line. Also, there is another randomization where again patients who are on tenofovir, there is a group which continued the same tenofovir. Another group was switched to AZT following the earlier guideline. The study carried out in sub-Saharan Africa, in Kenya, Uganda, and Zimbabwe in 7 sites. Where I will not spend much time on that, but I like to tell you because these results of this study has also been very relevant in our routine clinical care, as well as the talk which I'm going to talk about the 2 drug. So in that, what's been found in that is, despite you have tenofovir resistance, when they recycle the drug, still it worked, where 92% of them, when tenofovir has been recycled after failing, had virological suppression in second line. and as compared to 89% in age-active when it is optimized. So that means, one, our earlier recommendation with the WHO on switching to dolutegravir is a preferred option for second line as compared to a protease inhibitor. And also now, a newer PI, that is Darunavir 800, Ritonavir 100, currently available in India as a co-formulated tablet. It also can be an appropriate second line option as compared to the earlier what we have used on boosted dolutegravir, lopinavir, which has got toxicities, as compared to Darunavir 800 and Ritonavir. But very interestingly, the carry-home message from that study is part of those new guidelines, as well as the talk which I'll talk about more on, that is the tenofovir lamivudine. What we had been found that failure in the first line, and they recycle in second line along with dolutegravir. I'm using the word dolutegravir, worked very well. So following that, there will be a guideline recommendation will come up soon. If someone failed TLE, probably you can also change them to TLD. But again, during my talk, you need to remember that here you are using dolutegravir, not a weaker drug. Someone who fails TLD, don't change them to TLD, because efavirenz, we all know, is a weak genetic barrier drug. So this is something, some newer things have happened. And also in the new guidelines, just published 2021, also there are some new changes in the viral load monitoring. Earlier we gave a cutoff of 1,000 copies in the WHO guideline. Now that has been revised to less than 50 copies. Someone who is between 50 to 1,000, where you repeat within 3 months, and if persistently around 1,000, you can switch. Also in this new guideline, someone who is on NNRTI containing therapy, particularly with efavirenz or nevirapine, if they have a viral load of more than 1,000 copies, don't wait any time of reassuring them and repeat counseling and repeat the testing, straight away switch, because this any low-level viremia with NNRTI would have developed any mutations and will jeopardize and favor the virological failure. So hence you need to switch. This is something, a new recommendation, hence you can use it in your practice. Also, now we do have third lines, which you're also using, that is Darunavir 600, 100 twice daily, with dolutegravir once daily, if not used in the first or second line, twice daily, it's used in the first or second line. Also, in that recommendation, if you have access to genotyping, if any NRTA has got any activity, where you may recycle. So that means here you may sometimes recycle tenofovir, which you would have used in the first line, second line, and third line. So that means tenofovir is something like a mainstay drug in first line and second line. And of course, dolutegravir in first line, second line, third line, everything is a mainstay drug. So here again, my talk is all about when you're using tenofovir everywhere, what's going to happen. We have shown, our group of earlier shown here in Chennai, that the cumulative renal dysfunction to tenofovir over a 5-year period could be anything around 5.6%, which we have been published. And similar observations were also seen from a large cohort study which happened in Asia called Treat Asia cohort, where similar dysfunction had been seen. Also, the data now coming up from Africa, Latin America, very clearly shows that tenofovir on a long run is being toxic to the kidneys. To overcome that, we do have this TAF, which some of you have been using in your practice, which is tenofovir alafenamide, which is a prodrug of tenofovir, which again, you need a very small quantity, so it will not end up in doing more of a toxicities to the glomerular tubules, hence you can avoid the toxicities. So this is a study, sub-study of from another well-conducted clinical trials where they compared tenofovir versus TAF-containing triple therapy. Again, in this, they use integrase called L-vitagravir along with boosted with cobicistamine. So I'm not talking about that particular clinical trial's efficacy, but these are the patients who have got suppressed viral load. When they did the proteinuria, that is a quantitation of proteinuria, you can see on the left panel, the orange color one is the patients who were on tenofovir, and a purple one is on TAF. You see this huge amount of proteinuria when they continued this tenofovir, and when they dropped tenofovir and moved to TAF, that proteinuria improved. On the right side panel is on albuminuria, where again, you can see this someone who's on tenofovir, the continuously has been going up as compared to TAF. So someone who is on tenofovir, you may need to closely monitor the kidney function, because it can end up in renal dysfunction leading to this proteinuria. Also in the study, they also did DEXA scans on those study participants and try to understand the tenofovir toxicities on the bone. And what's been found in that in this study is when they looked into those Z score, if you see on the left side panel, there is on patients, index has been done on the spine and right side is on the hip. We see this orange one is on patients who are on tenofovir, who have a more binaural BMD loss as compared to purple color is on TAF. And when it has been switched at when they are on untitled viral load from tenofovir to TAF, and they looked at the hip, again, you can see, continue to see more BMD loss with tenofovir as compared to TAF. So that means tenofovir on a long run can lead to not only to renal dysfunction, but also to toxic to the bones, leading to fractures and BMD loss related complications. So following this, there are guidelines being developed for the Western world in the European Clinical Society and as well as the HSS guidelines. When someone who's been suppressed viral load, that is when their viral load is less than 50 copies, they're very stable, adhering to the ART, where can you drop tenofovir out so that people will get away from the toxicity, continue through other drugs. They did different clinical trials and different options were being earlier recommended since 2017. And one of those options is also on 3DC DTG, which I'll talk more on that, as well as DTG rilpivirine, and now some of those newer options. So, and these were being developed, these guidelines, based on different two-drug clinical trials, which are carried out mainly on patients who have got suppressed viral load as part of the maintenance. And also, a study had been done on patients for initiating treatment, on treatment-naive population, particularly with dolutegravir 3DC. So here, my rest of my presentation, lot will be towards on DTG 3DC, which again, now we have a molecule launched in India as Tunact with a combination of dolutegravir 3DC, where we'll walk through this clinical trial. Then after that, I'll show some carry-home message, what could be the appropriate population in India where we can provide with these medication. I'll also little touch upon DTG RPV and as well as some of the long-acting and newer molecules, but I will not talk anything about these PIs, two-line and other drugs, which not been recommended anymore. So one of those one of those main study which really changed the guidelines on two drug therapies, a study called Gemini. It's two different studies, Gemini 1 and Gemini 2. Both is a similar study design, but carried out in different regions. So this is on treatment-naive patients who are not exposed to any antiretroviral drugs, where patients who have been hepatitis B negative, and they have a viral load between 1,000 to 500,000 copies. He's been recruited for this study. So this is a very clean population, hepatitis B negative, because we all know that to treat co-infected people, we need both tenofovir and lenivudine or iptacopan along with that. That's the current recommendation by all our guidelines. And also it's a self-selected population with a baseline viral load of less than 5,000 copies. So it was randomized into two different groups. One group received a triple therapy of tenofovir, FTC, and dolutegravir. Another group is a study group with dolutegravir and 3DC, and the study went up to 144 weeks. So again, the primary endpoint being the virological failure of less than 200 copies at week 48. So this study, when they showed the week 48 results 3 years back, which is again not a new study, it's been carried out sometime back, where it very clearly shows, we see on the left side of your slide, the x-axis is duration follow, y-axis proportion of people with less than 50 viral load copies. We see these on these orange color patients who is on 3 drug combinations, and the blue line is on patients who are on 2 drug combinations. We see this almost superimposed. It is totally non-inferior, the 2 drug combination against triple therapy, even in patients who are treatment naive. But again, these are all self-selected population of less than 500,000 copies of viral load, hepatitis B negative. So the pool analysis of between both Gemini 1 and Gemini 2 done in 2 different regions very clearly shows that a 2-drug combo of dolutegravir and lemivudine is been non-inferior as compared to triple therapy in an intended treat analysis at week 48. So again, the study went on up to 96 and 148 weeks, and they found almost similar results in terms of both arms. There were few treatment emergent resistance mutations are seen, but there is no difference between the arms. It has been seen both in the 2-drug arms as well as in the 2 or 3-drug arm. There is no difference in between all this, like a typical clinical trial where treatment failure had been documented using the said definition on that. So following this Gemini study, US FDA approved this combination, which was developed as a lamivudine and dolutegravir, the name of Dovato, a couple of years back itself. US FDA approved, and they approved in a population with hepatitis B negative and not in tuberculosis. I'll talk about the TB later on. So it was being approved. But and also they very clearly said that you need to do a viral load. If the viral load is more than 500,000, you can't use it. But on the other hand, you can use it in a population which is suppressed and as a maintenance therapy. That's what the US FDA recommended. So once they recommended, there are several other clinical trials being carried out, mainly on maintaining this 2-drug option, whether it will be a good option as compared to triple therapy. It's very important because there are studies we have seen sometimes the shorter term, the first 24 weeks or 48 weeks, these drugs can be robust. And on a long run, sometimes they may lose the efficacy. So if you are going to do this for a maintenance, we need to have a long-term efficacy data. So again, this TANGO is a study which was being developed to go up to week 144. And again, this trial was carried out not in treatment-naive patients, these are all treatment-experienced patient who got a suppressed viral load, who's been hepatitis B negative. There is no NRPA or integrase resistance, where they were randomized into one group continued the same tenofovir or TAF-based ART with dolutegravir. Another group, there is a study group where they are maintained with the dolutegravir and 3DC. The study went up to 144 weeks with a primary endpoint of week 48 of virological failure using a typical FDA snapshot analysis where it shows which was being non-inferior. And very recently, in the recently concluded IAS conference, International AIDS Society conference 3 months back, and now it's been published, stating that even at week 96, the proportion of people with the target not detected is almost the same in both the groups, either with the triple group with the TAF, TC, and dolutegravir, or with patients on 2-drug therapy with the lamivudine and dolutegravir. When they looked at the elevated RNA, there is no difference between the two groups. Both groups have got almost the same. In fact, 6% in the 2-drug group versus 10% in the TAF-based ART. This very clearly shows that 2-drug options, even on a long run on week 96, is totally been non-inferior, and the efficacy is being maintained, in these options. So this is the TANGO FDA snapshot analysis week 96, where you can see this virological suppression, where you see, look at this bar. The blue one is on patients who are on 2-drug therapy with dolutegravir 3DC, and the orange one is on patients on triple therapy on TAF. So very clearly shows that DTG 3DC is have a higher virological suppression. I won't call superior, it's totally non-inferior. And again, when they looked into those treatment emergent resistance, which is almost similar in both arms, I think very significant to show that 2-drug has got a more resistance mutations. There was a theory that if you give triple therapy, it not only suppress the virus, but also it can also suppress some of those inflammation markers, thereby when people live longer with HIV, where we all know that they get aged because of inflammation. So where triple therapy has got some modest effect on that. They looked at this particular study in a post hoc analysis, and they found that there is no difference between different inflammation, because this is also important. As many of you know, as a practice inflammations, many of the patients on a long run, when they're on triple therapy, suppress viral load, they don't acquire any opportunistic infection, but they become morbid with myocardial infarction or worsening of some of those pre-existing comorbidities because of all this inflammation, similar like how we have been seeing in COVID. So in this particular analysis, they found there is no difference in between 2-drug and 3-drug. So that means not only being maintaining the virological efficacy, but also it is not altering anything in terms of these inflammatory markers. So hence this particular TANGO study, well-conducted study, very clearly shows that 2-drug option of dolutegravir 3DC is totally non-inferior over a very long period of 96 weeks, and not only being potent and durable, but also there are no major significant changes in the inflammatory markers. Also, this has also been supported by another clinical trial called SALSA. This again a trial where patients who had triple therapy, suppressed viral load, they're again randomized into two groups. One group received the current triple therapy with tenofovir, another one group received dolutegravir 3DC. Again, the results was almost the same. And patients who are on maintained with the dolutegravir 3DC, they have a 94% virological suppression versus 93 at week 48. Also in this study, the researchers concluded that it's totally non-inferior. No virological failure was been observed in two drug options. And also, looked at various body weight gain, and it was being seen as, this I will come to a little later on that when I talk about TAF combination, 2.1 kilograms with dolutegravir 3DC compared to 0.6 in the control group. And also the kidney function and bone parameters have been improved. I think that's important when you drop the tenofovir, where it has been renal safe and bone safe. So now, after showing all these various results like SALSA and Gemini and Tango, now we have this product now in front of you. It's been launched in India, a few days back or a few weeks back. That is as a name called Tunact, and as a fixed dose combination of lamivudine and dolutegravir as a single tablet. So now you may ponder around, now the drug is in your pharmacy in front of you. So what are you going to do with this product? Whom you're going to give? So you already have wonderful experience with the TLD, and now when this drug is being given, whom you're going to give? So I'm going to give some options, how you can use this in your practice to switch. Whom to switch to this, 3DC BTG Tunact? Anyone who's initiated on TLD and they have got a suppressed viral load, you can safely change them to that. Very important. They need to have a viral load suppressed, then you can change, because the studies very clearly shows that maintaining this is non-inferior and also saves the kidneys and save the bones. Someone who's already been switched from TLD, that is, you earlier put them on tenofovir, FTC or 3DC with efavirenz and change them to TLD on viral suppression. You have done a viral load on TLD, which have an undetectable viral load, then you switch them to TLD, and this is the group you can safely switch. So again, very clearly I put on viral suppression, but you change to TLD, maybe you can switch to. These are the two groups where you can, just like that, you can switch in your practice when you have that drug. TLD, suppressed viral load, TLD, suppressed viral load, and you change them to TLD, and you can, switch them to. Don't switch this 3DC combo to anyone who has been hepatitis B co-infected. As I said earlier, when someone is HIV and hepatitis B co-infected, the current guideline is you need to use a drug with tenofovir and lamivudine or tenofovir and as part of the triple therapy options. Someone who is TB co-infected, right now we don't have good data on it. As practicing clinicians, you all know that someone who is on dolutegravir containing therapy, when you give rifampicin containing TB drugs, you have to double the dose of dolutegravir. But those trials have been done, inspiring studies on patients with triple therapy, tenofovir, lamivudine, and dolutegravir. It's not been carried out with 3DC and DTG. We do not know about the PK data on that. So till we get more information, there are some groups working on that. Don't tinker on this particular population on these two drug options. And someone who's been failed with tenofovir 3DC and efavirenz, that is TLE, have a virological failure documented, don't switch to these 3DC DTG. So this group, you should switch them to DTG combination or to a boosted arachnavir or lopinavir or a boosted darunavir 800, not to 3DC DTC, because they already have resistance mutations to 3DC. If we just switch them, then dolutegravir might become like a monotherapy, which again, monotherapy trials with dolutegravir has been not been very successful in suppressing the virus. I'll now walk you through why you should not switch on this particular population when they've been failed. So let us go back to our first line, what we have been using. If you have been prescribing your patients on TLE, tenofovir, lamivudine, or emtricitabine with efavirenz, or with the nevirapine, when they fail, which we all know that the first thing which fails is always the 3DC with the mutation called M194V. Either along with that or soon after that, all the other mutations to NNRTA start developing on that. And if you continue them, then they can start developing K65 mutations to tenofovir. Actually, we found from TNRS study, almost 57% in Sub-Saharan Africa, and in Asia, 39% we have seen this. So, but very importantly, this M184 mutation occurs very early. So someone who fails, so that means 3TC is gone in terms of virological efficacy. And along with that, the NNRT is also gone. So again, if you take up this population to a 3TC DTG, then this 3TC may not have any activity on in terms of virological efficacy. Only the dolutegravir need to work on that, where again, dolutegravir monotherapy trials have shown it's not been successful on that. But if the patients who had used our former regimen, like AZT, 3DC, nevirapine, or they've used in the past stavudine, 3DC, or nevirapine, or efavirenz, again, similarly, the first mutation occurs for 3DC, and when they fail, also along with the NNRT mutation, subsequently with the TAMPs. So again, in your clinics, you have a significant number of people, you would also be moved them from AZT, 3DC, nevirapine, when they fail to TLD regimen. So those people, these mutations can get archived. So TLD, dolutegravir is such a powerful regimen, and tenofovir along with that would have suppressed the virus to an undetectable level till the patient is on your first-line therapy, or on a second line on a TLD. But on the other hand, they have an archived mutation of M184V, which is again may not have a virological success when you use it for to suppress a virus. Hence, never give this in a failed regimen, in any type of failure, even they have in a AZT, 3DC, nevirapine failure also. Also, if you have switched any patients from TLE to TLD without viral load monitoring. So that means you had put someone on TLE, so you do not know their viral load. Suddenly you switch them to TLD. Again, this is a very risky population because they can have a lamivudine resistance. Again, with the TLD, they can have a virological suppression. They would have developed a failure along with the lamivudine and efavirenz, which will be archived. And again, if you give 3DC and DTG in this population, may not suppress the virus. Or any previous history of AZT, 3DC, nevirapine exposure. But if there is a clean population with a suppressed viral load, then you have done a TLD switch, then that's fine. But otherwise, if you have done an empirical switch, because these are all very older regimens, now whenever newer regimens came, you would have switched those drugs, newer drugs on them. Then you may not know about those resistance mutations to 3DC. And any treatment interruption would have happened on NNRTA in the past. So that means when NNRTA resistance would have happened, where patients also would have developed the mutations to 3DC from the cartoon which I showed to M184V. Hence, may not be option if they have done any type of interactions. And in pregnancy, we all know that now TLD is a safer option in pregnancy based on all the studies and even the recent Zapoma study, where again, the combination with tenofovir, lamivudine, and dolutegravir is being safer, where again, it suppresses the virus in the pregnant women as well as prevents a transmission. So now this two-drug combo is not being studied in the pregnant population. So it might suppress, we do not know whether it will prevent the transmission. And because of the risk at this time, because of the lack of data, don't change the triple combination to this two-drug combination in a pregnant population. Again, the Western guidelines also don't recommend to do this two-drug combo in this particular population. So the patient population who really benefit from our clinic on who you have been following with your antiretroviral therapy on over a period of time is patients who have been viral load suppressed and renal dysfunction. So these are the population immensely will be benefited. Their viral load suppressed, drop tenofovir, give 3DC and DTG, where it will take care of their protect their kidneys and also will maintain the viral suppression. Someone who's been viral load suppressed and they have a history of any osteoporotic changes or osteoporosis, then probably this could be a good option to save their bones and from fractures and anything. Be a very good option. And very importantly, many of our patients, they live longer with our antiretroviral therapy. And many patients which we have started at 30, 35 years, now they are in 55 plus or 60 plus. And also we have a significant number of menopausal women on triple antiretroviral therapy, including with the tenofovir. So these are the very risky population who can develop a lot of other bone abnormalities as well as renal abnormalities because of their physiological function. So this is a population where you really need to target at this time with these two drugs in act. So where someone who's having undetectable viral load, especially in this population, elderly, again, use a definition of elderly in our country, so all postmenopausal. I think this is a population where not a significant number in our country, in your practice, where will be immensely benefited from these two drug options. And again, provided they have been virologically suppressed, because it will prevent a lot of their future toxicities one may develop on that. Hence, now this drug has been available based on this data, whichever I said, and based on the options which I said, based on that, you can sequence your drug appropriately. So not just this is only two drug options. We are also now having other options coming up. So there is a drug called Rilpivirine, which is not widely been used in India, because still under some of those experimental phase in India, but approved in many other countries, which is an NNRTI, which is a second generation NNRTI. So there are studies being done called SWAT study, which again, patients who got suppressed triple therapy to prevent tenofovir and bone toxicities, where they have done studies by comparing this two drug option of dolutegravir and rilpivirine, where it's been found that which has been non-inferior as compared to continuing triple therapy. And also in that particular SWAT study, when they did a sub-analysis using DEXA-scan on their BMD, where it's been found that both in the hip as well as lumbar spine, when you drop a tenofovir, where these BMD loss were able to be preserved as compared to when they continue with tenofovir containing therapy, they continue to see more and more BMD loss. So that means dropping tenofovir using other options like dolutegravir or rilpivirine is being beneficial. But again, this combination use as a combo is not available in India, but been approved as by US FDA by a name called Giluca. And what will be its role in developing country, where patients who have been virologically suppressed, no prior NNRTA resistance or integrase resistance, and no TB medications or hepatitis B co-infection, anyone with moderate or severe renal impairment, osteoporotic changes or CVD risks, probably this could be options. Very importantly, people who got any NNRTA failure, like TLE or AZT3 and everything, this will not be a good option because rilpivirine is an NNRTA. Now, just talk about the other possible options about the two drug options. And now many of you know that now we have got these long-acting injectable drugs coming up. So now we have this drug called cabotegravir, which is an analog of dolutegravir, which is also available as an oral tablet, as well as developed as a long-acting injectable with a half-life up to 40 days. Also, this rilpivirine, which I said drug which is an NNRTI, also been available as an oral tablet, as well as developed as a long-acting injectable with a half-life up to 90 days. Now, there is a trial happened called LATE-2, which I'll walk you through quickly in the next slide, which they have shown, efficacy on patients who have been suppressed viral load when you do that with every, 2 months dosing. Also, those results were well supported by two other studies called Atlas and Flare. I will also just browse through those data, which have very recently been presented and published based on the long-term safety data on that. So LATE-2 is a study which was conducted almost 4 or 5 years back, where they compared patients who had triple therapy, suppressed viral load. They randomized into 3 different groups. One group is continued the same triple therapy with the bacavir, lamivudine, and dolutegravir are one of those options they have been using. And they were they were being randomized into 2 different groups. One group received, there is every month of a long-acting injectable with the cabotegravir and rilpivirine with a little lower dose. And another group which received this long-acting cabotegravir and rilpivirine every 8 weeks, that is every 2 months at a higher dose. And they found in that these patients who are on every 2 months, they got a higher virological suppression. But again, not statistically significant, totally non-inferior as compared to the triple therapy. Again, when they looked at the injection site reactions, again, it has been done either every month or every 2 months. Not significant to discontinue. Patients still like that, having more and more injections on that. But only caveat being, someone who's with the injectable rilpivirine needs a cold chain where it need to be refrigerated. So that's something, caveat on this. Now, this particular Atlas LATE study has also been well supported by another trial called Atlas, where again they use every 4 weeks of rilpivirine injectable as a maintenance therapy, and they found totally be non-inferior. And again, now these following these study results, the combination of cabotegravir and rilpivirine is also been approved for use as Cabenuva by the US FDA. So week 48 results have been already been shown that even every 8 weeks, it's been non-inferior to every 4 weeks. And very recently, the week 96, that's the long-term data had been shown, both in terms of virological efficacy as well as safety, very clearly shows that on a 96 weeks data, every 8 weeks of this long-acting injectable is totally non-inferior as compared to every 4 weeks, and also quite being safer. And you can very safely recommend to your population who got an undetectable viral load. But again, caveat here being is a rilpivirine. Anyone who is coming in NRTA resistance or they have a previous history of NRTA failure, this may not be a right option on that. And these results were also been supported by another trial called FLIRE study, which again, they used every month this long-acting injectable. Again, study was been planned up to 104 weeks data, where again, they compared this initially with the triple therapy. Then once at week 96, viral load suppression had been done even with triple therapy, and also with the 2-drug injectable, all the groups went into the maintenance of every 4 weeks of injectable, cabotegravir. Where again, the very long-term data very clearly shows that it continued to show maintain the virological suppression, and there is no significant safety events to report on that. And it's been very clearly recommended that it's been well tolerable and it's been, been efficacious. So what are those advantages of this long-acting antiretroviral injectable, especially in our settings? We all know that our patients on a long run, they have been fed up with adherence issues because of these patients who need to take these medications every day. They have this pill burden, fatigue, and the various stigma issues taking this drug in front of them. And this long-acting therapy offers a possibility of directly absorbed therapy because this can be given either every 4 weeks or every 8 weeks. I also have newer long-acting coming up, which I'll talk to you soon on that, about every 6 months. These are the options where you can give us a directly absorbed therapy. Also, especially in people with the pill fatigue, it's an attractive option. Reduces stigma. No one wanted to take a tablet in front of others. But the caveat being, today, now with the wonderful regimen of TLD, our patients are well set in our practice. They come at baseline, you see them at the first month, do a creatinine and look for adherence. Do a viral load sooner at 3 to 6 months. Then after that, you're going to see them only every 6 months. You're giving a long prescription. Also, we do have multi-month medications bottles available where the drugs have been kept for 3 months, where patients are very happy with this and set up. But now, when you want to give this long-acting injectable, you need additional follow-up. They have to come every month, where again, you need a clinic space to give this injection, because these injections have to be given on the buttocks, where you need a private space to do that, which many of the clinics in India where they practice ART may not have that. But also the safe disposal of needles and cold chain for rilpivirine. These are some of those caveats where we'll limit this usage, particularly in a resource-limited setting. We cannot give in hepatitis B and TB. But on the other hand, if we do have a long-acting TLD, which we have been working on, probably could be an option. Right now, we don't have the option. Only available recommended by US FDA is cabotegravir and rilpivirine. Having said this dolutegravir, which many of you know that you have seen in your practice, you have seen this, patients are all put on weight. So when we are bringing as a 2-drug options by dropping tenofovir to save the kidneys and bones, but on the other hand, dolutegravir, either you give us a triple options or a 2-drug still can make someone to put on weight. So weight gain is an issue. To address this, a very nice trial happened in South Africa a couple of years back called N Study, where they used 3 different regimen options on treatment-naive patients, one on triple therapy with the efavirenz-containing therapy with tenofovir, another one tenofovir with DTG, another one TAF with TC and DTG. I think I would have shown this group in the past. Both showed equal virological success. When they did a sub-analysis, they found that particularly with an option of the TAF, FTC, and dolutegravir, mainly in a women population, they have a huge obesity issues, which was very clearly shown in this particular slide, On the left side is on weight gain in patient men, where orange color is patient with efavirenz containing therapy with tenofovir. Lighter blue is tenofovir with dolutegravir, and the darker blue is with TAF, FTC, and dolutegravir. It clearly shows that with the TAF and dolutegravir have a more weight gain. Even if you don't want to give tenofovir, you want to give TAF, this weight gain will be a huge issue. But it's particularly huge issue on in women population. So again, this might be a race specific and sex specific, which need to be further studied in India, because we have got different races and different population, which again, you have been seeing this, but we need to study that, whether this could be an appropriate option, again, in our patient population. To avoid that, now there are some newer drugs in pipeline. Many of them are in the very advanced phase 3 trial. A drug called NK8592, also called Lyracobavir, which is again an NRTI, but it acts at the translocation level, which I talked about on that. Also been developed as a long-acting, can be given as a two-drug option. Also, there is another new molecule called capsid inhibitor, which has also been developed as a long-acting, can be given as a two-drug option. Let me quickly go through this and maybe throw one for questions. So Lyracobavir is a molecule which inhibits reverse transcriptase by preventing the translocation. And also the preliminary studies have shown it may be even people who have got NRTA resistance, even to tenofovir will work on that. So it has been hypersusceptible. It's been developed both as an oral tablet as well as an injectable. So again, various dose ranging studies have been done, where in that they have shown that starting with a triple regimen with Lyracobavir and doravirine is another NRTA with 3DC, once suppressed, then when they move them to two-drug option with the Lyracobavir with the doravirine is an NRTA, had a comparable virological efficacy as shown in this graph as compared to the triple therapy options. So following this particular study showed that a two-drug combination of Lyracobavir, which is a reverse transcriptase inhibitor inhibiting at the translocation level, along with the doravirine, can be a good two-drug options. So right now, this drug was studied as an everyday oral tablet, but also this Lyracobavir is also being developed as a long-acting, even as an oral tablet. So again, now we have a longer data also available as till week 96, where again continue to show that it's been efficacious and there is no major safety concern. Also, as I said, it's not only as a long-acting injectable, this oral Lyracobavir has also been developed as a long-acting oral tablet, mainly for PrEP. Again, they showed that this particular drug, if you give it a higher dose of 60 milligrams, has got a drug level in a way that it suppresses and prevents viral acquisition. So now there are treatment trials are going to be happening on this oral long-acting drug, whether this will also suppress the viral replication by preventing, by suppressing the virus, which again, we need to wait for this trial results. So to add along with that, we also need other drug where there is a new molecule called Lyracobavir, which is again a capsid inhibitor has been developed, but it's an injectable. Every 6 months it can be given, both oral and as well as subcutaneous preparation is being developed. But in a trial called Capella, which is again was being carried out in a treatment experienced population, where they have shown, as shown in this design of the study, patients who have been suppressed to viral load were being randomized into different groups. One group with viremia, they added an oral Lyracobavir initially for 14 days. Then they gave every 6 months of subcutaneous Lyracobavir. Also, it's been compared against a placebo against a failing regimen. Also, there is a group who have been suppressed viral load, but continued to use oral Lyracobavir with optimized regimen for 14 days, then moved them to every 6 months of subcutaneous. So what they found in that every 6 months of this Lyracobavir showed, virological suppression. These are all treatment experienced population of more than 80%. So which has never been shown any of those severely experienced patients in the past, even with the protease inhibitors. But again, it's such a powerful drug, can be given as a long-acting every 6 months, especially in people who have been treatment experienced. Looking at the injection site reactions, there are no significant adverse effects that have been seen. Again, it's every 6 months. Nobody discontinued therapy. Everyone had their second or their third doses or on that. And following that, this Capella trial showed that in a treatment experienced population, every 6 months of this Lyracobavir, along with optimized background regimen, it's been virologically been efficacious, hence can be recommended in our therapeutics. Can we give this drug in a treatment naive? Again, it was also been shown in a study called Calibrate. So this is a trial where patients who are ART naive, who have been initially given an oral lead-in phase, then once viral has been suppressed, they have been maintained with the subcutaneous injections with the Lyracobavir along with the TAF as a 2-drug options, and another arm with the Lyracobavir subcutaneous every 6 months with Bictegravir. Another group, continued these oral therapy. Again, in this very clearly has been shown, all the groups have equal virological success. Again, it's a treatment-naive population, such a powerful drug, it's a 2-drug option. And it's been very clearly recommended that, these drugs can be used as a long-acting drug, even can be given as a 2-drug options along with another powerful drug. Again, before I conclude my talk, now Gilead is, who developed this Lyracobavir, also been developing various broadly neutralizing antibodies. One of the things they have been doing is to combine along with the Lyracobavir, where again, broadly neutralizing antibodies can also be given every 3 to 6 months, whether this can be a future option. That means someone who's already suppressed viral load, you can move them to the Lyracobavir every 6 months and probably broadly neutralizing antibodies every 3 to 6 months. This is something will be a future treatment option. We don't have this drug right now. We showed some promising results. Probably in the next few years, this may be an option, especially for our patients who have been totally tired of taking these pills, every day. So to conclude my talk today, we do have this powerful, wonderful TLD option, but on the other hand, it can do its own nuances. To avoid that, now we can reduce this drug exposure by dropping this tenofovir as a 2-drug option currently available, 3-DC-DTT. Also, you should look for some of the newer drugs in the pipeline. Many of them will also be available in India for a period of time by our Indian generic partners. Also, many of them are now being developed as a long-acting drug, not just for every month or every 2 months, but also for every 6 months. Watch for it. I think these are some of the things you will be using in your practice. I like to conclude my talk and throw upon for questions that with all these powerful antiretroviral drugs, either triple or 2-drug, we're able to suppress a virus. Despite all this suppression, HIV persists because of various factors. We are not able to cure or eradicate, so it still persists. Cure has happened only in 2 patients, which we all know that it's a Birding patient and that's a London. Birding patient unfortunately died recently, not because of HIV. He's been HIV negative because of other complications. But functional cure is more of an achievable. You start with a TLD, suppress it, then you can release the tenofovir, put them on 3-DC-DTG, maintain them, and do the close viral load monitoring on them. And the trial data have very clearly shown on a long run, it's maintained the virological suppression. With this, I'll stop my talk again. Thank you for this opportunity and happy to take any type of questions. Again, thank you very much.
Thank you, Doctor. Very exciting and interesting talk. Particularly the long-acting oral. I think that's going to make a significant dent in the way we treat patients. We have a few questions. First will be a question from my own question. It's quite personal because I've been involved with the NEED 001 ANRS 143 study, which is the first 2-drug combination that was compared with a 3-drug combination. Now, the study did show that darunavir and raltegravir given together was non-inferior to darunavir, tenofovir, and emtricitabine, but that never kind of kicked off, though it was non-inferior. So what do you think is so exciting about this combination of dolutegravir and lamivudine, which is new and which has more acceptance for treatment?
So I think it's a good question. 2-drug option is not new. In fact, our own group, we did a second-line study, the famous second-line study. Patients who failed first line, we randomized into different groups. One group received the standard of care of NRPIs and a boosted PI. Another group received boosted PI and an integrase inhibitor. In the second-line study, we used raltegravir. And subsequently, there is an NIH-funded study called ACTG 5273 called SELECT. We use a similar. All those showed 2-drug therapy with a combination of boosted PI and an integrase inhibitor, where in those studies we use raltegravir, which is non-inferior as compared to triple therapy. There's no doubt in that, even in patients who have been treatment failed with NRPI. So, but on the other hand, right now we are also been involved in another trial using Darunavir 800, 100, along with the dolutegravir 50 milligrams in patients who are failing TLE, a study called DEFT, which we have been enrolling in our site here in Chennai. So this will also give a very critical answer, especially on the two drug options. But here again, the issue being these protease inhibitors, which we all know that protease inhibitors has its own. It's been such a powerful drug. Darunavir is such a powerful drug, but it's had, when you boost it with the ritonavir is not a good drug. So which can cause a lot of the metabolic complications, body shape changes, and so many other things. And also now with the dolutegravir, we are seeing all those gains, not only with dolutegravir, with all the integrase inhibitors, including with other newer integrase inhibitors, this weight gain is an issue. So I'm not sure that giving a protease inhibitor and an integrase as a true drug option, for anyone as part of the first line therapy. Maybe for a second line where you have a first line failure had happened from the results from the second line study or from a select study or from our outcome of the newer studies which now currently been happening, and all those probably could be an option.
Okay, thank you. So just a statement for the audience. You can type your question in the Q&A section and the chat section, and I'll be taking them up and asking Dr. Kumarasamy. So some of the questions that have already come. Would you recommend genotyping for resistance before switching to Twinact?
Right. So I think I gave a lot of options, in my slides. These are all my own, views from the published studies. From studies who are on treatment name as well as for maintaining therapy, that I gave different options. So I think someone who's already on TLD, well suppressed, clean published, who are initiated on TLD, well suppressed, you don't need to do any genotyping. Just you can move them to 3D-CTG. Someone who was on TLE, who never had a failure, probably you have been following the patient. So not been followed up in some other clinics, or who had moved from some of those government ERT centers to you, not that population. Who have been you have followed, you have done regularly viral load every 6 months or every year, always suppressed viral load, never had a treatment failure. Then that can be a population. If they are virologically suppressed, just move them. You don't need anything else. Or from a TLE, virologically suppressed, move them to TLD. A couple of years back, now you can keep. These are population you don't need to worry about the genotype. But on the other hand, someone who has been TLE failed. So these patients need a second line option, not a two drug option. Based on the Nadia study, from TLE you can change to TLD, or if you want to give a PI, you can give TL and boosted arachnavir or lovinavir or Darunavir 800, or if you want to give a Darunavir 800 and dolutegravir as a combination. So those population, even if you do a genotyping, I'm not going to recommend that using the results to be a true drug option. If you do a genotyping, eventually you'll have M194 mutation for lamivudine, which I showed in that cartoon. And of course, they will have an NRT mutation, and they can have K65. Even if whatever mutation they have, you're not going to recommend this true drug option. So doing a genotyping is not an option, for that particular failure. So another one where you may ask me a question on genotyping, someone who has been on TLE but failed earlier. So now you are changing them to TLD. They have been well suppressed. Now probably they'll have mild viremia, where 1,000 copies or 2,000 copies, where you can send them for genotyping. So in that population, you may see a 3TC mutation because they're still being using on that. Or even if you don't see any mutation also, probably I won't recommend, because these patients would have developed a 3TC mutation and they would have been archived. So here, when you have been giving this 3TC and DTG, you need to have activity of DTG, as well as also you need to have activity of 3TC. Why I'm saying this 3TC activity is needed, because there were, just for one of time, I didn't show some of the dolutegravir monotherapy trial because all showed negative results. So dolomono and all the trials, anyone, were given dolutegravir as a monotherapy, either in patients who are on initiating treatment or who are on switching, all had failed over a period of time with the dolutegravir mutations. So I think with all those, doing a genotyping there and picking up, you need to be a very option. I think safer option is clean population of TLD or TLE, very cleanly characterized by you and Buddha. Somewhere they were on ACT, 3DC, neverapine, change them to TLE, then to TLD. These are the population I will be, because DTG is going to be a very important drug for first line, for second line, even for third line as a twice daily. You know, if you lose that, then your whole antiretroviral therapeutics sequencing will be gone till we get some of the newer drugs, which I said, like the Lyracobavir, Lyracobavir. It may take another few more years to get it to your patients.
Okay, I think you've answered a couple of more questions that were there. So one question we've got from Sumati is, what about switching from TLE to TLD if the viral load is 760? So I think it's quite specific. Maybe she has a patient with this.
So I think TLE 760, I will move them to TLD, you know, because recently the Nadia study very clearly shows that you know, you can very safely do. So whenever you do such switches, especially in your private practice, do a frequent viral load. When you switch them from TLE to TLD, do a viral load in the next 2 to 3 months. Now, if they have been well suppressed, you are very sure that you know, they have been suppressed. Then repeat after 6 months. If you suppress, then after that every year. Thereby, where you'll be able to maintain. If after 3 months it's not been suppressed, then you'll know that there is something happening. Then don't meddle with the regimens. You know, do the proper, move them to the second line drug.
So I think you spoke about switching from TLD or TLE to lamivudine and dolutegravir. There are some questions about other regimens. So for example, if a patient is on tenofovir, 3TC and atazanavir, or who's taking Inbec, so that's abacavir, dolutegravir and lamivudine. And would you recommend switching them? And if they are being suppressed and failing on the regimens for?
Yeah, I think I covered this during my talk. I think when someone who is on second line already on atazanavir, so that means they have already failed first line, you know, with the lamivudine and NRTI mutations. Hence the reason that you have moved them to atazanavir. So in that population, I will not recommend, because the patient will have 3TC mutation, even if they are well suppressed, because boosted PA is a powerful regimen. Even if they have 3TC mutation, it will suppress this. So in that population, if you remove this atazanavir and tenofovir out and give dolutegravir along with 3TC, probably they may end up in a failure. So I will not recommend in that population.
There's a question on the NACO guidelines. So what this doctor said is that so NACO guidelines, they still believe viral suppression is less than 1,000 copies. And they say when there is a like a blip or an increase of more than 1,000, they're asked to increase the adherence and repeat viral load after a few months. So what is your opinion on that?
So I showed a newer guideline from WHO, which eventually will be adapted by NACO. I think they have a technical research group meeting, you know, being planned for that. So our earlier guidance is someone who have 1,000 copies, who is on TLE. That's a majority of the regimen patients were on in the national program earlier. So you actually counsel them and do a viral load within 3 months. And if they are not suppressed, the viral load goes more than 1,000 to switch it. So now the newer guidance will be someone who is on NNRTA for a long run. If the viral load is more than 1,000 copies, no need to again counsel the, and of course, counseling is very important. No need to wait for another repeat viral load 3 months and look for it, change it. This is because NNRTI is a weak genetic barrier drug where mutations will start developing. And also we feel can also accumulate other mutations. So for that reason, better to switch it, which will be adapted eventually by NACO over a period of time, because now it's a new WHO guidance, which was released during the ISBA.
What about a patient who is on first line abacavir with dolutegravir and lamivudine?
So someone who is on abacavir, lamivudine, and dolutegravir on first line, but never exposed to NNRTI or never failed a first line therapy, if they are virologically suppressed, that will be the best population to give this to next, because you are given abacavir because they have some issues with the renal. So that's the reason you are chosen. So that could be an excellent population to move to next. provided they are virologically suppressed.
What's your opinion on dolutegravir-induced hypoglycemia?
So these reports are also been coming up, not only from India, now been getting reports coming from Africa. So also we have seen there is a small group of people with the worsening of the diabetes mellitus. So it is again a new area of science with dolutegravir. More work needed on this. Is it been happening in everybody, or is something on pharmacoeconomics? These are some of those which need to be studied. So again, more and more guidance will come upon, particularly in patients who have been diabetes in the usage of dolutegravir, as well as who has been hyperglycemic. So right now, we are not asking to do any other changes. If they are diabetic, continue to follow those medications. And we are not asking anyone to avoid DTG, because same thing happens with protease inhibitors also. We have seen with all the other PIs in the past. So right now, continue to do that. But this hypertriglycemia, hyperglycemia is continuously being seen in a small set of patients.
In case of renal dysfunction, do we need to change the dose of lamivudine?
Yes, of course. We have a grade to do that. I didn't put any slide on that. So someone who is having a renal failure, I will not recommend Tunact directly, because Tunact will have a 300 milligram of lamivudine and 50 milligram of dolutegravir as a combo. So in those individuals, you have to use separately, lamivudine separately based on the creatinine clearance. Either you need to give 50 milligrams or 100 milligrams or 150 milligrams or 300 milligrams, depending upon the creatinine clearance. We need to have a chart on that. I think for the group, someone who asked this question, I have the chart I can email. If you can type in the chat, probably later we can do that.
Okay, all right. So I have a couple of more questions, after which I'll be taking a few people on board on the panel so that they can ask you questions directly. Okay, so why was 3TC chosen as a backbone? Since the M184V mutation can develop early, and then this combination will turn into monotherapy.
Right. So I think the only currently one of those options, for our first line, second line, we have been recycling 3DCs. For first line, it has got a virological effect on suppressing the virus. In second line, despite their failure, even not only new in those years when we used D40 3DC nevirapine, when we changed them to second line with tenofovir, we recycled 3DC RFTC. Same thing, when they used tenofovir 3DC, we again recycled. That is because when you combine 3DC with an NRTI, particularly with the tenofovir, now there is a synergistic effect and there is a viral fitness theory. And because of that, it has got an effect on the, particularly on the, even on the second line. Similarly, with the AZT, when you combine the 3DC, it has got enough synergistic effect on it. But that effect is not with the dolutegravir. When you use 3TC and DTG, that's the reason I said when someone failed the 3TC, I think you should never use Tunact, because you need a virological efficacy along with dolutegravir. So, but when you combine along with tenofovir, it does a different effect in suppressing the virus in terms of the viral fitness series. That's the reason we've been continuously being used as a 3DC. But we don't recycle 3DC in the third line if you're not using any NRTI. For example, if you're going to use Darunavir 600 and 100 twice daily and dolutegravir, we're not going to use 3DC because 3DC will not have a virological efficacy. It will also work on that viral fitness theory. And now with some of the newer drug options coming up, as I said recently on Lyracobavir and Lyracobavir, I think this 3DC might be put to a rest maybe over a period of time. But still will be a good drug in a developing country where we have high hepatitis B prevalence, anything from 5 to 15%, depending upon where you live.
Okay, Dr. Kumarasamy, I'm going to invite a few people on the panel, starting with Dr. Vinay Kulkarni. Dr. Vinay Kulkarni, you're on the panel right now. If you can unmute, please, and ask your question. Thanks.
Oh, thank you. Thank Kumar. Excellent talk.
Hi, Vinay.
Yeah. I'm not going to ask you any question. It has been very nice to hear you after a very long time.
Thank
I
you.
already asked my questions.
Mhm.
Okay. Thank you, Dr. Vinay. Sheila Galwankar. You're on the panel. If you can unmute and ask your question, please.
I have no questions. The talk was very good.
Thank you.
Your question, Dr. Sheila?
No questions.
I think there are few hands been raised. I thought probably they were all been asking questions.
All right, yeah, I'm calling them in. Dr. Karthikeyan?
There was a question in the chat box on the neural tube defects.
Yeah.
So this has been described earlier in the, with the dolutegravir. There's a study happened, it's an observational study from the pregnancy registry in Botswana called SAPAMA study. Initially, they have shown in 4 women. And subsequently, when they followed that up over a period of time with more and more women who received dolutegravir in the first trimester, they did not see that as compared to efavirenz, which subsequently been well documented and published. And right now, the neural tube defect theory is being born. So, but still, any drug you give in the first trimester, can have any effect. I'm not saying that all drugs have been safe, including AZT, tenofovir, and everything, can have some type of an effect. But still, right now, our major objective is to prevent transmission. To do that, we need to have a virological suppression. Right now, TLD is such a potent drug, which will prevent viral suppression in a pregnant woman, even in the first trimester, which will prevent transmission to the baby.
Okay, I think those are the questions. I've invited Dr. Karthikeyan on stage. He's on mute, but I guess he's not responding. Okay, so Dr. Kumarasamy, just I would like you to maybe a couple of sentences on a couple of take-home messages which you think our audience should focus on from this talk.
You're asking me to do that?
Yeah.
So I think since this talk is on tonight, I think this drug is now launched in India, available to you. I think use those guidance, whatever I said, prioritize your population, elderly, postmenopausal women. So these are the population where they have high risk to develop a renal toxicity to tenofovir, and postmenopausal women to fractures. I think these are significant number of your population, maybe 30 to 40% in your clinic. In my clinic, might be around even 50% of my population is all belong to that group. So I think that population should be targeted first when they are virologically suppressed. Then we can move them to the other patients who are on TLD, well suppressed, or TLE suppressed, move them to TLD. I think you should do in a very systematic way. And very important carry-on message, the minute when you move, make sure that they are very adherent to them and do a first initially one viral load within the first 3 months, so that you are very sure, patient is also very assured that they are suppressed. Then after 6 months, and after that, our routine every year viral load monitoring. I think that's very, very important. And before you do that, rule out hepatitis B. If you're not done that, it's very important. If they are hepatitis B positive, the 2-drug option is not recommended. And also, they should not have tuberculosis. I think these are some of those your carry-on messages at this time.
Dr. Kumar, Balaji, once again, just one observation. One important slide which was in your presentation was where you should not be using this drug, this 2-drug. Now, can I infer that this drug could be given as an incentive for those patients who are adherent and those who are virally suppressed and those who do not have hepatitis B or TB co-infection? Would this be the first set of patients who would sort of get incentivized by the tenofovir getting dropped?
Yeah, of course. That's what you prioritize a population. Prioritize a vulnerable population first. Then you move them. Similar like how we did the COVID vaccination. No? We gave all the 60 plus, 45 plus healthcare workers. Some similarly like this, you prioritize. Maybe over a period of time, everybody will get it.
So from your experience in the Indian population, what percentage of patients would qualify for this drug from the three-drug switch?
So depending upon the clinic, you know about our clinic, we've been taking care of patients for many years, more than 2.5 decades. So we have a very large number of patients who have been undetectable viral load, who are all elderly by definition and postmenopausal women. I think it's anything around 40 to 50% might get into this group. So I think this might be. This varies from different. Some of your clinicians who are in this meeting who have been practicing very large enough. Dr. Vinay Kulkarni, I know him more than 2 decades. He's been more than 2.5 decades. He's been treating patients. There are many other doctors. So I think they might be having that populations. So I think that's important. So varies from clinics, and someone who is younger, make sure that they adhere to the current triple drug, then move them to the 2 drugs. The 2 drug, if they are not adhering well, probably dolutegravir might be gone. So now TLD, we have seen people who had missed 1 or 2 days of pill. Again, when they restart, suppress the virus. I think you have to make sure that commitment from a patient that they adhere to this drug very well. I think a lot of counseling needed.
Fine. So which means that there could be approximately 50% of the patients who could qualify for a twin act switch.
Yeah, because a lot of our major HIV epidemic, in India happened sometime in the year 1999 to 2007 or 2008. That's a time where these patients were on 30 or 35 plus, started on antiretroviral therapy. So now almost 15 years are gone. So these population now crossing 50 years. So where the huge chunk of Indian HIV infected people have been diagnosed during that time. So that's the reason I said around 40 to 50. So, but I may be wrong, maybe a little lower, may not be much deeper down. Again, we didn't see much new cases in the last 2 to 3 years, again, because of this pandemic.
But with the introduction of dolutegravir as a triple drug regimen, would you find more number of patients moving into the category of virally suppressed, and therefore over a period of time qualifying for a 2 drug switch?
Yes, eventually, that's what the TLD switch to 3-DCTTG will be the first option. But again, someone who had been failed TLD, switch to TLD, even if there's good adherence, good suppressed, those individuals should not be switched to 3-DCTTG. So that's a very important take-home message. People who have failed TLD, this option should not be recommended.
That was very interesting presentation, Doctor. And do we have any unanswered questions, Dr. Rohan? Any other new questions that have come in? I think Doctor has taken quite a good amount of time from Doctor. It was very comprehensive.
Yeah.
So if there is no more questions, thank you very much, Dr. Kumar, for a very comprehensive presentation. And it's been a very pleasant evening to be listening to you. You also touched upon some of the future avenues of triple drug or 2 drug therapy, including long acting and all that. Yes, but these are still at a distance, because we still have to look at how the regulators will be looking into the data that is being presented to them, and then how it gets into the WHO guidelines and then trickles down into the in-country guidelines of the several countries.
Yep.
So we are all on it. We would continue to push ourselves into getting more simplified regimens to the patients. But until then, of course, I think the Twin Act is definitely a paradigm shift from a 3-drug regimen that we have been following all these decades. Looks like seems to be an interesting tool in the hands of the physicians, and a good incentive for those patients who are adherent and virally suppressed.
Good. So thank you very much. And also thank you for all the compliments in the chat box from many of the doctors. So looking forward to continue to chat with you all, maybe in a different forum. So thanks again for this opportunity and stay safe. Thank you.
Thank you. Thank you very much, Doctor.
Bye-bye.
Thank you, Dr. Rohan.
Thank you.